Hello, everyone. My name is Trish Penner. I completed my practicum with Island Health Public Health. Within my practicum, I had the benefit of being able to work on a variety of very interesting projects and initiatives. The one I am presenting on is what I also wrote my culminating report about, which is developing a model of group visits for immunization in child health clinics. Each of the initiatives and projects I worked on were under sort of the umbrella of quality improvement. Public health uses the Island Health principles of continuous improvements to identify and address client-centered targets and gaps in service. One particular method of continuous improvement include PDSA, or Rapid Improvement Cycles. PDSA stands for Plan, Do, Study, Act, in which initiatives or projects are trialed, assessed, and then retrialed. This is intended to incrementally improve the functionality of a program. Even small improvements are considered worthwhile. Due to ethics approval and time, my culminating project really focused just on the P, or the planning portion of this cycle. So in September 2014, an Island Health Committee held a full-day forum to brainstorm and produce a list of recommended strategies to improve childhood immunization rates for children under the age of 7 years old across Vancouver Island. Their strategies were based on best practice and expert discussion. Currently, the rate for children under the ages of 2 are approximately 69 to 70%, with the goal being 95%. One of the major identified reasons for this gap by Island Health is that there are long wait times for immunizations in some public health units. One possible strategy to address this problem suggested was to trial a group visit model in which several families attend a shared clinic appointment. My role as a public health practicum student was to work on 3 complementary aspects of this initiative. The first step was to research the literature on group visits, particularly group visits in a public health context, and review the medical models that are currently being utilized. The second was to use information from the literature and the current state of child health clinics to create a potential model of which a group visit might look like. The third was to create a set of reference documents so that in the future, a public health unit were interested in implementing this initiative, they would have a plan to refer to and to alter to suit their needs. This included a project charter, a succinct literature summary, a logic model, the workload assessment tool I took part in developing, an implementation plan, a communication plan, and an evaluation plan. So this here is a chart of identified benefits from the General Practice Services Committee website, which provides a pretty accurate summary of what I found in the literature. This is from the physician model currently being used in BC. Some of the key potential benefits include increased efficiency and capacity, reduced anxiety for patients, peer support, and the chance for mutual learning. Some potential challenges found in the literature included that scheduling a group is more challenging than just individuals, and that some clients might have more complex requirements that aren't well suited for a group, and that staff would require group facilitation training. The next step for me was developing the project charter and the logic model reference documents. So this here is a more simplified version of the logic model. The plan for this process is really quite straightforward. There were no additional resources allocated to this initiative other than my time and the time of the public health nurses, managers, and admin staff, along with a space to implement future trials. Activities would involve researching, then trialing the process, and the output would be the initiative being actually implemented. The intended impact centers around efficiency and maintained satisfaction for both clients and nurses, and the long-term increased capacity in clinics. I'm sure you can't read the tiny little words, but this is a Gantt chart, which is of a timeline that was included in the implementation plan reference document. An implementation plan outlines when and how much time may be necessary for each step to put this initiative in place. It supplements the project charter, and in this case, it served as a guideline as each of the other reference documents were embedded within it. So the next step for me was to work on the current state assessment. In order to implement and evaluate a group visit model, it's necessary to examine what CHCs look like now. I could easily do a whole other presentation just looking at the workload tool. It was adapted from a time-based audit workload tool for community nurses. This measurement breaks down complex public health nursing work into sort of discrete activities, and then through developing consensus, measures how much time and how often each activity takes place. The next piece to understand the gap between current need and capacity is to do a 10-day audit of the number of people requesting an appointment and comparing that to the number of available spots for appointments. The final piece was to look at how client appointments currently go through a process called client journey mapping. So this is a client journey map. Above are the steps for the client, and below are the process steps for the volunteers, the public health nurses, the admin staff, and the clients themselves. Basically, the client books their appointment, they arrive, they're seen by a public health nurse, the child receives their vaccine, waits 15 minutes, and then leaves. So this here is a potential future model for the clinic in a group visit. All the red boxes indicate process steps that would change with this model. I don't expect you to be able to read any of those tiny little boxes, and I'll highlight the differences in the next slide. The main change is that before the client has their vaccine administered, they would instead meet as a group and discuss the child health portion of the appointment and receive informed consent. The key changes are also what would be highlighted in the communication plan as a reference document. The key changes would include the clients meet in a facilitated group to go through the informed consent process, the infant health assessment, and discuss health concerns in a group. What would stay the same is that clients would still receive the vaccine in a private space where their consent would be confirmed privately. There are several challenges we found in creating this model. One is that clients would necessarily need to have longer appointments, which they might not be on board for. Another was in maintaining safety and standards for charting. And then another one is that there is sort of a minimum time required to actually administer and chart a vaccine. And when we're adding more people, we're multiplying that number. So the final piece for the reference documents was this evaluation plan. The evaluation plan is divided into 3 measures: process measures, determining if this process does in fact create efficiency and save time for nurses; balancing measures, whether the high level of care already provided by the nurses is maintained and whether the staff is satisfied with this new model; and the final outcome measures, which are, is there a measurable decrease in the gap between need and capacity and whether the wait list is in fact reduced. This initiative is not really intended to solve the problem exactly, but to create measurable improvement. And so just to finish it off, I want to say a million thank yous to my supervisor, Helen von Buchholz. She's been an amazing mentor and so incredibly supportive. I also want to thank Hillary Planding, Connie Hasselden, and all the ladies at the Saanich Health Unit for being so receptive and patient with me. And I also want to thank Victoria Barr and Kathy Worthington for their support. And just one last thing, I want to make a shout out to my sister and my family. Thank you.
Lovely, Trish. Thank you. Questions for Trish? Welcome, sister. Where are you, sister? Oh, you're the sister. It's nice for you to go.
Great job on your project.
Thanks.
It's pretty fascinating, and from the earlier discussion that we were touching on for the clinic settings and the long wait lists.
Absolutely.
I just wondering if any part of your project started to look into some of the barriers that might be created, and I'm just thinking specifically to identifying vulnerable families and the sensitivity for trauma-informed care within a group setting.
As I was developing this model, and we did have a chance to trial it, but it wasn't sort of included in my report, that there are a considerable number of barriers. For example, someone who's ESL would have a really hard time in a group setting. Someone whose child is behind would have a really hard time in a group setting. I think one of the mitigation strategies would be to have an additional staff on backup who would be available to work with that person one-on-one, or they would be referred to an individual appointment later that day or at a different time.
Anyone else? Do you want to do some concluding comments? Well, of course. Of course you do. Thanks very much, Trish. That was awesome.